Okay, good afternoon, everyone, and welcome. My name is Tista Day, and I'm an obstetrician and global maternal health PhD student at the University of Liverpool. And here at Glow, we've been so excited for the Year of the Nurse and Midwife. And today we are thrilled to share our top 3 presentations on respectful care and the Year of the Nurse and Midwife. So we're going to play each presentation and then have a short 5-minute Q&A with the presenters. Please do send all your questions into the Q&A app on the side of this screen, and I'll share as many as I can with the candidates today. Any that we're not able to answer to, you're able to pick up later. Okay, over to the first video, which is Moana and Anna on training health professionals to communicate with emotional competence to provide humanistic care. Over to your video.
Hello everyone, my name is Monavua Boga. I'm a nurse manager and a trainer on health communication and emotional competence for health workers in Kenya. I train health workers on how to communicate respectfully with patients and how to manage the many emotional challenges that they face in their workplace. So we all know how it feels to be respected. It feels so good and it feels so wonderful. But we also know how it feels to be disrespected. It's very hurting and it can be very dehumanizing to be disrespected. So respect is a core value in the medical and nursing profession. And respect enables us to build trust with patients and to build professional relationships with patients. And when patients are respected, they feel good, they feel valued, they feel safe to open up their innermost concerns. And this enables us as health workers to really emotionally connect with them and offer care that is humane and care that is very respectful. But however, we know that disrespectful care is very common globally in the healthcare system. There are reports in Kenya of how mothers face abuse when they go to deliver. And I know most of you may be aware about the Francis report of how patients face disrespectful care in the NHS in the UK. So the question we're asking ourselves is, why do health workers disrespect patients at a time when patients are so vulnerable, when they need to be shown kindness and care? So there are so many reasons why these behaviors happen, and one of the main reasons is that health workers work under very stressful situations. They were dealing with death day in, day out, handling very difficult situations, dealing with our own emotions, our own fears and frustrations. So all this can really influence the way we communicate with our patients. And emotional labor, it's not taught in our medical and nursing curriculum. We do not have the skills to really manage these situations. And also there are other reasons why health workers disrespect patients, and mainly the national and medical hierarchical systems where respect is shown upwards. So we expect patients to show us respect and not vice versa. And also the lack of consequences of disrespectful behaviors among health workers. So we disrespect patients and we walk scot-free in this behavior. So it kind of continues because we are not punished for it. So the question we're asking ourselves is, how do we train health workers to manage these emotional challenging situations for them to be able to offer care that is respectful? And this is the training that we run in Kenya to equip health workers with these necessary skills. And the training we use is called the iCare Haaland training model. And it's a training model that was developed by Anna Haaland, who is a social scientist from the University of Oslo. And she has developed this training with users, with nurses and doctors in different contexts in Eastern Europe and in Africa. So the training aims at addressing health workers' communication challenges at the workplace. And it's a process training over 9 months. And why 9 months? Because we are targeting attitude and behavior change. And we cannot quick fix bad behaviors or bad attitudes. We need time to do that. So the training is 9 months, and it has phases of self-observation and reflection at the workplace using guided reflective assignments. And then we build in experiential learning workshop where the health workers learn these skills to care. So how does the process work? So the main approach we use in the training is the self-observation and reflection at the workplace, real time with patients using guided reflective assignments. So we give the participants an opportunity to reflect on their own communication behaviors with patients, and they get to see when they treat patients well with respect, what that means to care for the patient. And they also get to see how disrespecting a patient feels, and they see their behaviors real time, and they see that when they disrespect patients, patients feel hurt, they close up, and they're not able to share their concerns. So when health workers see the disrespectful behaviors, they discover the need to want to change. They feel that this is not the way I want to treat my patients, and they discover the need to want to change. And this really rekindles their motivation to offer care, to offer better care to patients. So this is the process that we use in our training. So what results are we seeing using this process? So across the 9 countries where this training model has been implemented, we have seen a reported increase on patient providers' ability to offer respectful care. They're also reporting increased awareness on how they respect patients, and also they are reporting increased awareness on the ability to recognize their own emotions, patients' emotions, take a step back and control their emotions, to take responsibility, to communicate well. And once they are able to do this, they say that it really helps them to manage stress and burnout. So they report increased job satisfaction. So these are key changes that we are seeing using this model. And just to focus on the aspect of respect, what we realize that, especially for the training in Kenya, at baseline, most of the participants were not aware of the need to show respect for patients. They felt that it's the patient to show respect to them and not the other way around. But throughout the training process, they recognize their own power position as health providers and how that influences the way they relate with patients. And they're also able to see the effects of not showing respect to patients. So by the end of the training, most of them actually changed their perception on how to treat patients as fellow human beings. So most of them, they acknowledge that they're now treating patients better than before, and they're able to handle the many emotional challenges that they face. And one example of such kind of a change is an example where one of the health workers reported that how she handled the mother differently from before. And this is an example where she said the mother did not know what to do and started breastfeeding her baby, who was very sick in distress. And she removed the baby from the oxygen. I almost yelled at her because the baby had gone into apnea. I became aware of wanting to react and stopped myself. I gently asked the mother to hand over the baby to me. I resuscitated, and afterwards I explained to her about the baby's condition. Previously, I could have yelled. So these are some of the changes that the health workers are reporting in terms of how to handle their own emotions. And another example that they are also sharing is, when I treat patients with respect, I stay stable. I have noticed that when I treat patients with respect, they are easier to handle and are less fussy. They seem to gain trust and confidence in me. And when I treat patients with respect, I stay stable and strong. So these are some of the key changes that the health workers are reporting using this training approach. So in summary, we are saying abuse and disrespect is very common in the healthcare system, where there is need to empower health workers with the necessary skills to manage the many emotional challenges that they are facing at their workplace, to become aware and treat patients in a manner that is respectful. And these skills are currently not taught in the nursing and medical curriculum. So there is need to really teach health workers these skills. And we have seen from our training model that it's possible to train health workers on these skills using experiential learning and reflective practice. So we are saying that when health workers show respect to patients, it influences the quality of care they give, but also it also influences it improves their own well-being and job satisfaction. So our recommendation is that the nursing and medical curricula need to really focus on training health workers on emotional competence in their nursing and medical curricula. Thank you.
Okay, thank you so much. That was absolutely fascinating. And actually, to hear a little bit more about the importance of respectful care in terms of communication, too, is just hugely, it's something that I don't think we've got that much training on, really. So I really applaud you for the work that you're doing.
Thank you.
You mentioned that the model could be used for 9 cultures or across 9 cultures. How did you manage to make that applicable, and is it generalizable for other settings as well?
So this model, as I said, was developed by Anna Halland, and she has used it over 9 countries in different contexts. But what is coming out clearly is the problems that health workers face. They are quite similar. Whether you are in Nepal, whether you are in South Africa, whether you are in Kenya, the problems are similar. And from this conference, that has come out quite clearly. So I feel that this model is applicable anywhere in the context of where health workers are working.
Okay. And
Yeah.
in terms of making it in methodologically, would you use the same methods that you've used just as is to in different settings, or would you start from the top again, or would you want to just use the model as is?
Okay, so that is one of the challenges that we have been facing, that more often people want a quick fix. They want short training, they want to see results
Mm,
immediately. And it's not possible, as I've said earlier on, that when you're dealing with the attitudes and behavior change, you need to give you need time. And according to the literature that is out there in terms of how best to train health workers on communication training, there are key things that we need to observe according to the literature. That one, the training should be longitudinal. It should use critical reflection. It should have process, group process. And so there are critical issues that we need to observe for us to train health workers on communication training that is effective. So the quick fix does not work, and the evidence is there that short trainings do not usually lead into behavior change. So
okay.
in any setting, we highly propose that this model be used the way it is. There are some
Mhm.
small adjustments we have done, but the critical thing that leads to the change in this training is the reflective period and the experiential workshop. So those are things that we critically feel that they should not be lost in the model.
Thank you, Mona.
Yeah.
And Anna, what if you were to say what is the main reason for participants' change in behavior? If you were to pick one, because I imagine there are quite a few, but if you were to pick one, what would you say that main change was?
I think the main reason they change is that they are allowed to discover for themselves what kind of problems they have, and they can decide what they want to change. It's not me or Mona or anybody telling them that you're a bad communicator. When they do the observation and reflection and they see that they hurt other people, they start to take responsibility for their communication and they stop blaming others for them. So it creates an inner motivation to change based on what they have experienced, and that's why it is so strong. So we started in Lithuania, and we have also trained in Wales in the UK, and it's the same kind of reactions people have. It's like, oh, my God, I do this? No, that's not what I want to do. So inner motivation to change and taking responsibility for the change themselves, not people pointing fingers.
That's fantastic. Okay. Well, I'm sure people will have some more questions to ask you, so please do filter these in the Q&A app. And we're going to move on to our next presentation, which is from Antona Asifa. Thank you, Anna and Moana, for being here. Thank you so much. Moving on to Antenna Asifa, your presentation is on imagining maternity care as a complex adaptive system. So we're going to play that now and then take some questions afterwards. Thank you.
Hi everyone, I am Antenna Asifa from the National Institute for Global Health at the University of Melbourne. I will be presenting on imagining maternity care as a complex adaptive system, understanding health system constraints to the promotion of respectful maternity care in Ethiopia. As a background, in Ethiopia, there has been a remarkable improvement in maternal health. For example, maternal mortality reduced from more than 1,000 in 2000 to almost 400 in 2019. Similarly, the utilization of maternal health care services increased significantly. However, there is a mismatch between antenatal care and facility-based childbirth. This shows there are women who had at least one antenatal care visit during their pregnancy, but who still deliver at home. Among the main reasons that result in outside health facility delivery or childbirth in Ethiopia are perceived poor quality of care, bad experience of facility-based childbirth, disapproval from elders, nighttime labor, hostile or unfriendly staff, disallowance of birth companions, lack of privacy, and poor structural readiness of health facilities. This constellation of factors are nowadays labeled as mistreatment or disrespect and abuse. In response to the increasing levels of mistreatment during facility-based childbirth globally and in low and middle-income countries, the World Health Organization included respectful maternity care as one of recommended practices for positive childbirth experience. Accordingly, the WHO defines respectful maternity care as the care organized for and provided to all women in a manner that maintains their dignity, privacy, and confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during labor and childbirth. Accordingly, respectful maternity care spans the health, legal, human rights, political, and social sectors. And it is also an issue of people-centered healthcare. This study aimed at identifying health system constraints to the promotion of respectful maternity care in Ethiopian health facilities. And we used the displayed conceptual framework to unpack or identify barriers to respectful maternity care implementation at individual, facility, program, and socio-political levels or factors. This study makes part of an interventional mixed methods design that was conducted as part of my PhD study. So the quantitative wings included survey of women and survey of service providers, and the qualitative ones included focus group discussions with service providers and in-depth interviews with coordinators and managers. This particular study reports on the qualitative wings. The other components will be reported in two poster presentations that are also presented in the GLOW. The intervention included 3-day respectful maternity care training to staff who work in labor and delivery wards of the hospitals, placement of WHO infographic wall posters, and post-training on-site continuous quality improvement support. The intervention was implemented in 3 hospitals, 2 general hospitals, and 1 primary hospital in southern Ethiopia. From the 7 FGDs, 4 of the FGDs were conducted pre-intervention and 3 were conducted post-intervention to explore how service providers experienced the respectful maternity care training and the challenges that they encountered in implementing the respectful maternity care recommendations. And there were also additional 12 in-depth interviews with hospital administrators, service coordinators, and a program manager, which were conducted all pre-intervention. For data analysis, we used a hybrid thematic analysis approach that used both inductive and deductive approach. The deductive approach depended on the complex adaptive systems theory, which I'm going to describe. So a complex adaptive system is a type of system that comprises diverse agents, and the behavior of each agent is responsive to the interactions with other agents within the system. So there are different subsystems with cross boundaries and that exhibit dynamic interaction or relationships, and their behavior is determined by that dynamicity or complexity in interactions. So using the hybrid thematic analysis, we identified 7 major themes with regards to health system barriers to the implementation of respectful maternity care. And we classified those 7 thematic areas into system hardware and system software constraints. The hardware included issues regarding bed availability, infrastructure and supplies, financing, and health workforce, whereas the system software included staff motivation, service providers' mindset, and awareness of respectful maternity care. Here are pictures that show the challenges in the study hospitals. As you can see, there are 4 birthing coaches in one room without a physical compartment, and you can see the existing privacy screens are very old and with rusts. And one of the hospital coordinators said the main challenge in their hospital is shortage of beds, especially during the night time. Sometimes it is the gatekeepers who tell women coming by ambulance to turn around and look for other hospitals in the city. There are also issues or challenges in terms of shortage of service providers because of financial constraints, and also there are issues related to delay of reimbursement of fees for maternal health services from the Ministry of Health. In Ethiopia, maternal health services waived, but the hospitals get reimbursement from the Ministry of Health. So one of the managers said there is a huge delay in getting costs incurred for the delivery of childbirth services, and that is significantly affecting the quality of service that they provide to women and their families. Here, the causal loop diagram shows how complex the respectful maternity care service provision is in the study hospitals. There are different problems in those 7 categories or health system constraint categories. For example, issues related to supply, issues related to financial shortage, issues related to staff retention. So the relationship or the interaction between those different compartments is very complex, as we have seen, and some exhibit positive feedback loop as can be seen from workload and fatigue and turnover of midwives. The more midwives leave the hospitals, the more the remaining will be exposed to higher workload, and that repeats itself viciously. So there were complex interactions between various system elements in the absence and with the presence of the intervention, and a system constraint can affect both clinical and non-clinical maternity care components in various ways, and an intervention component may have a positive or negative consequence on other components. For example, in this study, after the training, service providers allowed women to have their birth companions, but that affected the privacy of other women, especially during vaginal examination, and that practice was terminated afterwards. The study is unable to explore how systems adapted further after the post-intervention FGDs because of resource constraints and short follow-up after the intervention in this study. So the way forward is strengthening health system using bottom-up and top-down approach to intervene at micro, meso, and macro level. Here I have synthesized evidences from various studies conducted in Sub-Saharan Africa and in Ethiopia to show how respectful maternity care can be intervened at women and community level, service providers and managers level, health facility level, and national level. And the bottom row shows various interventions that were identified to be effective in yielding results. In summary, promoting women's rights through respectful maternity care, advocating providers' rights, and health system strengthening results in the elimination of mistreatment and improved quality. That would in turn provide improved institutional delivery, which results in reduction of maternal and neonatal mortality. Not only this, respectful maternity care also improve positive childbirth experience among women. I would like to thank all partakers in this study for financially supporting my PhD study and all study participants who took part in our study. Thank you very much.
brilliant. Thank you so much, Antonella. That was a huge amount of work to have done, and you came up with some fantastic solutions, both on the micro level and macro level, which is fantastic. I wonder how well did these solutions, how well were they uptaken by the stakeholders or those able to govern the micro and macro levels? How to improve respectful care?
Yeah, thanks, Testa. Can you hear me?
Yeah, I can hear you.
Yeah, thanks, Testa, for the question. Yeah, actually, this study was conducted in collaboration with the Ministry of Health and the Regional Health Bureau in southern Ethiopia. So they were the ones who supported or who financed the respectful maternity care intervention in collaboration with partner organizations. So as has been mentioned yesterday in various sessions regarding implementation science and implementation study, it is very important to generate buy-in of stakeholders. So accordingly, what I did was I collaborated those entities from the very outset, so they were involved in the design of the respectful maternity care intervention, in the implementation, in the post-training continuous quality improvement support. And then later, after the analysis and report of the study findings, we have developed a policy brief for the Ministry of Health, and that has been published and it has been shared with professional associations, partner organizations, teaching institutions on the way forward to integrating respectful maternity care in pre-service curriculum.
Okay, fantastic. So, and I completely agree. I think sometimes to try and make it sustainable, we think these solutions are just on a unit level. And actually, if we want to make the change that we need to, we have to involve those higher levels so it can trickle down into all the institutions and organizations involved. Did you find that there was a particular part of the obstetric continuum, so either antenatal care, intrapartum care, postnatal care, where you felt there were bigger barriers to providing respectful care?
Yeah, as Manwa mentioned in her study, in this, in our particular study, we have identified that there is perhaps awareness and knowledge gap regarding respectful maternity care, but improving that or addressing that is not adequate because there are a constellation of health system factors or challenges that still prevent health service providers from implementing respectful maternity care. That is why we posit respectful maternity care in a complex health system. So it is very important to approach respectful maternity care from different dynamics, not only from a behavioral approach. As you have said, there is a gap in terms of identifying where, like, majority of the problem happens in terms of mistreatment. Do we have adequate evidence regarding mistreatment during pregnancy? That is a very important researchable question these days. During my PhD, what we did was back in 2014, I led a study that was conducted in southern region of Ethiopia. So we recruited women who had at least one antenatal care visit. So from those women, 62% of them delivered at home. So that shows you, yeah, the missed opportunity. Women are coming to our health facilities, but they are not giving birth with us. What is the problem? That also indicates some issues regarding perceived and experienced mistreatment of women. So what we are planning in Ethiopia now is to do a longitudinal study, recruiting women starting from as early as possible in their pregnancy when they start to seek antenatal care in health facilities and see their experience and track how they end up in the maternal health service continuum, because that also affects the service that they seek postpartum for their own health and for their newborn's health. And that should be a big priority. Yeah.
Yeah, no, and I'm so glad, because that was going to be my next question, is actually where do you go from here? So it sounds like you've got some really incredible studies lined up, and actually that wealth of information is going to be hugely informative, not just in Ethiopia, but for the rest of us globally as well. So thank you so much for being with us today and to present your work with us. I will keep the Q&A session going. And if there are any questions that flag up for Antona, please do post them. And Antona, I welcome you to answer these for anybody that wishes to ask you anything further. So thank you for being with us. I'd like to move to our final speaker, who is actually live here today, Terry Khanna. And Terry's actually on our local steering group committee for the GLOW conference as well. So we're really glad that she's here and able to speak to you live.
Thank you.
We'll just start by playing her presentation, which is on the daily reality faced by nurses and midwives providing midwifery care in Bangladesh and Malawi. Thank you.
Hello, my name is Terry Khanna. I'm a registered general nurse and a registered midwife working at Liverpool School of Tropical Medicine. This presentation uses qualitative data I've collected for an ongoing PhD programme and is on the daily reality faced by nurse midwives providing midwifery care in Bangladesh and Malawi. Globally, midwifery has seen a resurgence, with recognition of the need for a skilled midwifery workforce. Midwives and midwifery are central to efforts to improve the quality of care provided to women and their infants. However, there's a global shortage of midwives, and to overcome this, many countries have created the nurse midwife cadre or have upskilled nurses to provide midwifery care. But to have a real impact on maternal and newborn health, midwives and nurse midwives need to be deployed as members of a competent maternal and newborn workforce, and they need to work in a well-functioning health facility with a good referral system. To achieve this, we need to understand the working lives of midwives and nurse midwives to be able to support them in their desire to provide quality midwifery care. This presentation is using qualitative data collected in Bangladesh and Malawi during 2016. The diary keepers were nurse midwives and worked in BMOC and CMOC facilities. They were selected from 4 districts in each country. They were provided with pre-formatted diaries and asked to list the 3 factors that helped them have a good day at work and 3 factors that contributed to a bad day at work. There was also a text box for comments. This was used much more by the nurse midwives in Malawi than in Bangladesh, and the diaries were kept for 5 working shifts. The key informants provided both personal and official views on the current scope of practice and workload of nurse midwives in their country. Initially, it was planned to have focus group discussions, but this was not possible due to the small numbers of nurse midwives at the facilities and not being able to meet at central points. Therefore, small group discussions were held with 3 to 5 nurse midwives at each facility. The next 5 slides are the main themes identified through thematic analysis and are the words of the nurse midwives. The green areas represent Bangladesh and the blue Malawi, with the darker shades being a positive view and the lighter shades being a negative view. They show that the working lives of the nurse midwives are very similar in each country, and the differences are dependent on the context. Like in these findings, what makes a good day at work often mirrors what makes a bad day at work. Teamwork, or the lack of it, was a strong theme in each country. The nurse midwives were task-orientated. They were happy when they could complete all their allocated tasks during their shift and that they could have time to have a chat and a joke with their colleagues. Conversely, what made a bad day was when they went home not being able to finish their tasks or that they had to work later to complete their tasks, that they didn't get help when they needed it. And one of the main challenges for nurse midwives was when they needed to get a doctor to review a patient and they were too busy to come. On the days with clinics such as an antenatal, family planning or child immunisation clinic, the nurse midwives said they were too busy. They worked without a break and often beyond their shift. They said there was no system to get this time back. When there were enough nurse midwives and support staff on duty, they said they could cope. However, in Bangladesh, nurse midwives said they were often too tired to meet their family responsibilities as a wife and mother. And in Malawi, a nurse midwife described being the only nurse midwife on duty during a night shift and having to support 12 women to give birth. She said this wasn't unusual. In both countries, the availability of resources and supplies directly impacted on the care nurse midwives provided. They associated having the right drugs, functioning equipment and other supplies as being able to provide good care at the time needed. In health facilities where the sterilizer was broken, nurse midwives expressed dismay that they had to use equipment that they considered dirty. In Malawi, the effect of the water shortages and electricity cuts caused much distress and anger. The nurse midwives explained how they couldn't wash their hands between clients, how they were expected to support women during birth in candlelight, and sometimes care had to be delayed until daylight. In both countries, the relationship between the nurse midwife, women and their families was a source of much discussion. It had a great impact on the shift in either a positive or negative way. When the women and their families behaved and cooperated with the nurse midwives, it made the shift much easier. They gave examples of families helping by caring for women and fetching water when needed. However, the behaviour of family members were also a source of great stress and tension, especially in Bangladesh. Nurse midwives described being threatened by family members and having to ask the hospital security to intervene. One nurse midwife said that after such an incident, the family had warned her that they knew where she lived. The majority of nurse midwives really enjoyed working in the maternity department and especially on the labour ward. In Bangladesh, nurse midwives were very positive when they discussed their job satisfaction. They described a good day as helping the women and the babies, completing their tasks, receiving compliments from the families, and that the ward was clean and tidy. In Malawi, job satisfaction was more mixed. The majority of nurse midwives were happy with their work. However, a significant minority described their anger and a feeling of burnt out because of the working conditions. Good days were associated with having enough staff on duty, teamwork, the presence of doctors when needed, and sufficient drugs, equipment and supplies. Bad days were described as not having help when needed, a lack of resources including water and electricity shortages, and when family members were uncooperative. Overall, the majority of nurse midwives were positive about their work. However, their work environment can be stressful and busy with large numbers of women and their families to manage. All these factors can impact directly either in a positive or negative way on nurse midwives' ability to provide quality midwifery care. I would like to thank all the nurse midwives and key informants for taking the time to share their opinions and experiences with me. As a nurse and a midwife myself, much of what they said resonated with my own experiences. The nurse midwives who spoke with me were proud of being a nurse midwife, but felt that their work was compromised by the environment and context that they worked in.
Brilliant. Thank you so much, Terry, for that. That was fantastic. And actually, you touched on something at the end, which was exactly what I wanted to ask. that you, being a nurse and a midwife, and having worked both in the UK and other settings, how much did you feel that the findings you'd found matched the experiences that you'd had yourself?
I think it doesn't just apply to a nurse and a midwife. I think it applies to anyone at work. We know that when we get on with the people that we work with, when we're working in an environment that we feel comfortable in, we are able to do our work well. And when we feel underappreciated, disrespected ourselves, or we don't have the equipment to do the job well, then it causes a great deal of stress and frustration for us. So I think that I empathised a lot with them, and I think as a researcher you have to guard yourself sometimes, don't you, that you don't sort of bring that bias to it. So I found it quite difficult at times because I thought, oh gosh, yeah, now what would I do now? How would I manage? I had worked for a long time as a community midwife in North Wales, and going out to home births at night time in a vehicle with all my equipment, so I was safe. But then thinking about being a nurse midwife on a labour ward with 10 women to look after, maybe 15 in labour by myself, and I we can't provide quality care in that situation, and all the practitioners know that, but they're powerless to make a difference in many situations. So it is a very difficult situation that we are in.
And where do you, I think that was a really good point about that ability to detach yourself from something that is so innately part of your life and an experience that you would have had. How did you find being able to detach? Was that an easy process, or was it a difficult process? Or
I think I have to thank my supervisors in many respects to be mindful, say, well, Terry, is this your view, or was this the view of the nurse midwives? When I was in the field, I think, when I was talking to nurse midwives, I think being able to tell them that I was a nurse and a midwife myself, that it helped to build that rapport. I had an understanding of what was happening, and because I had also worked in some respects as a nurse and a midwife in low resource settings, I was able to, the situation that they were working in was familiar to me.
And so that is something to relate to you as well and be able to be part of the session too. Do you feel that there are any gaps or opportunities where, or if you were to pick sort of 3 big opportunities that we could have in order to improve an experience for healthcare practitioners being able to carry out their job, where would you say people should focus their energies on?
Oh, that's a good question. I think we need to train people well initially. And I think if we can really provide a good training, an effective training that empowers nurses, midwives, medical doctors, all healthcare professionals, that we understand the work that we need to do, that we are able to critically think, that we understand team dynamics and are able to communicate. This all goes back to all the conversations we've had throughout the conference about respectful care. And I think, to me, that is a starting point. But when we then put that new person, new professional in an environment that is compromised, how can they function? How can you work without electricity? How can you work when you can't even wash your hands between your clients? It's really difficult. So those sorts of, the infrastructural problems need to be addressed. And then I think finally, it's about the support that we give each other, that we have that mentorship, that support when we're first qualified or we're working in a new environment, that we help each other, that there's that teamwork around us, and that we are allowed to grow. But also there's someone there, like was said before, that when we make a mistake, that we have that time to reflect on what has happened, and that people help us rather than just being critical towards us. So I think those 3 things, good initial training, then working in an environment that supports us to do our work, and then having mentorship and a supportive framework around us when we start on this career.
Brilliant. No, I think that's given us some really great nuggets to focus on and continue this discussion, hopefully, through the app which I have gone on for the entire session, and I really hope you will be able to use it more through the chat and through the Q&As. So please do continue giving all presenters as much questions or feedback as you can, as there's some really fantastic projects. And what I think one of the key themes that perhaps I'm taking home from today is actually the ability to provide respectful care and the importance of quality care is not just an individual basis, but actually that these are wider processes that start with education. And just going from the first session that we had, looking at being able to train emotional competence and how can we be able to do this, to then looking at the wider stakeholders that are involved, which the second presentation went on to see how these barriers exist and where we can act. And then also to actually, as Terry mentioned, speaking to our healthcare workers that are working on the front line and understand that there are different aspects that we can, and gaps and opportunities where we can address these issues that are multifactorial. So I want to thank you all for joining us in this wonderful day. I hope it's been informative for you all and that you've learned something that you knew or something you didn't realize. And please do continue to communicate with our wonderful presenters ongoing. So thank you. Our next session after this will be the How to Run a Virtual Online Conference, which will be starting at 4 o'clock British Summer Time, GMT +1. So we look forward to seeing you there. Thank you very much.